Good morning, everyone. A very good morning to you all. We have joined today for yet another webinar series organized by the Society Health Research and Innovation of the General Medical Officers Association. Today, we will be discussing about a very timely and an interesting topic, lipids. Are we managing them right? Before moving on to the lecture, let me walk you through some of the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. This is to improve and maintain the quality of the CPD programs conducted by the Shri, and we thank you dearly for adhering to these rules and regulations. And about the questions, there will be a question time at the end of the webinar. You can type in the questions you have in the chat box and make the settings as all attendees and the panel. Also, if you have very specific questions, you can email them to office313@gmail.com. Moving on to the lecture, today we are talking about lipids. Are we managing them right? And our speaker is Dr. Situmini Pahalagamage. She's a consultant physician in the Institute of Infectious Diseases, Colombo. Over to you, madam.
Right. So today we are going to touch upon something very important that sometimes we tend to, for many reasons, not maybe not manage properly, or maybe don't give enough importance to in our management. So this is about lipid management. Most of us, we are used to do a lipid profile on a patient, and if the total cholesterol, or mostly if the total cholesterol is high, then we look at we are used to look at the reference ranges given by the laboratory, and if our actual test value is higher than the reference ranges, what we do is we start on a statin therapy. That was our like management few years back, and unfortunately still that is being done quite commonly, we have observed. And so I thought this is a timely topic to be discussing here today. And so this is the lecture outline. I'm going to touch upon briefly on the lipid metabolism and identification of groups in need of lipid lowering therapy, and outline the targets to achieve in each of the groups, and also briefly touch upon the agents available to help achieve targets and the mechanism of action. So it's in managing lipids, it's important in managing lipids, it's quite important to know what happens in our body, and just to understand this metabolism of lipids in the body. So it's very important to understand what happens to our lipids and how the lipids are formed, and what lipids are good and what lipids are bad. So lipids, basically, we ingest lipids, right? And we ingest lipids, we ingest fatty acids, we ingest and we ingest cholesterol. We ingest fat and we ingest cholesterol, and these are absorbed through the intestine. And through the intestine, this is absorbed as a molecule called chylomicron, which is which is a big molecule, mainly carrying triglycerides and only some cholesterol. And then these chylomicrons are metabolized by lipoprotein lipase in the body, and some of these triglycerides are being taken away and metabolized, and free fatty acids released for energy production. And a molecule called chylomicron remnant stays, and this is being taken by the liver. So in the liver, what happens is some cholesterol gets added to this chylomicron remnant, and a lipoprotein molecule called a very low density lipoprotein is being made in the liver. Now, this very low density lipoprotein also contains a lot of triglycerides and some cholesterol. And this contains something called apolipoproteins, ApoE, ApoEC, and ApoB100. These molecules help with the further metabolism of this VLDL molecule. And VLDL molecule is put out in the circulation. And in the circulation, again, lipoprotein lipase acts on this VLDL, and this is further metabolized. Triglycerides gets taken away, and the cholesterol content in this lipoprotein molecule generally increases, and VLDL becomes IDL, intermediate density lipoprotein, and then intermediate density lipoprotein becomes LDL, low density lipoprotein. So these with the removal of triglycerides, the lipoprotein molecule gets smaller in size and it becomes low density. And this low density lipoprotein molecule contains a lot of cholesterol. Low density lipoprotein molecule is taken by other tissues like muscle and the rest of the body, endocrine organs, all these organs, and it's used to produce your hormones and all the other things, steroids, everything. So it's very important to understand this. And then this LDL molecule is taken up by the liver again. From all these lipoproteins, we say that LDL, the smallest molecule, this small molecule, LDL, is the culprit responsible for atherosclerosis. It's because actually that's not the case, but it's mostly the LDL. Even the IDL, even the VLDL, these particles can also be taken up, but the smallest molecule is taken up quite easily, and that is the culprit, the main culprit in atherogenesis. And also I want you to make note that all these cholesterol lipoprotein molecules contain a molecule called ApoB100. The ApoB100 helps in the cholesterol molecule in entering the cells, and that is again a risk factor, like because ApoB100 helps in the cholesterol molecules to move into the cells, that helps. Any molecule containing ApoB100 can increase our risk of atherogenesis. So the small LDL particles, this is a schematic diagram of atherogenesis. The small LDL particles enter through the intima, enter through the endothelium into the intima, and sets about this inflammatory reaction. Because of this inflammatory reaction, the circulating monocytes come into the intima and becomes a macrophage, ingest all these oxidized LDL particles and form a foam cell. And again, because of this inflammation, an atheroma forms. When this atheroma becomes unstable, it ruptures and forms a thrombus. So that is basically what happens with our atherosclerotic cardiovascular disease. And so cardiovascular disease, as you all know, is the leading cause of death worldwide. 30% of all deaths, 1/3 of all deaths are due to cardiovascular disease. And hyperlipidemia is identified as a major modifiable risk factor for cardiovascular disease. When we look at the Sri Lankan context, as a Southeast Asian population, we are anyway at high risk of coronary artery disease. That is a known fact. And here also, if you look at the data available, cardiovascular disease is still the leading cause of death. And overall prevalence of elevated cholesterol among Sri Lankan adults, as published in a survey done by Ministry of Health in 2015, is said to be 23.7%. And if it could be even higher, because there is a study available which says 77.4% of Sri Lankan adults had some form of dyslipidemia. So this could be somewhere in between this or towards the higher value. So it's very important that we understand lipids and we take measures to manage it correctly. So how do we set about managing lipids? There are two groups of people. We can control lipids in people who have never had a cardiovascular disease in the past. That is called primary prevention. And then there is a group who has already suffered atherosclerotic cardiovascular disease. And those, when we give statins to, when we manage hyperlipidemia in those people, that is called secondary prevention. Let's see how we get about that. So, in a ministry guideline for primary care physicians in Sri Lanka, this was given. And it's reasonable. We can screen all apparently healthy people above 35 or even less than 35, persons aged between 20 to 35 years having the following risk factors like smoking, overweight, obese, and abdominal obesity, high blood pressure, and diabetes mellitus, and again, history of premature cardiovascular disease in the first degree relatives. Premature cardiovascular disease in males is when it happens less than 55 years, and in females, it's when it happens less than when they are less than 65 years. And history of diabetes mellitus in first degree relatives, and history of familial dyslipidemia, familial hypercholesterolemia, and those things. We can, if they present to your practice, even your GP practice, when they present to your hospital, we can do a total cholesterol on them. If that is more than 240, we can go to fasting lipid profile. And about this lipid profile, you know that of late we say lipid profile doesn't need to be fasting always. It's because fasting only, it requires a long duration of fasting, say about 12 to 14 hours. And our patients are often not willing to do a lipid profile because of this prolonged fasting. It is said that only triglycerides in our lipid profile will change significantly if we significantly even with a meal. So with a meal, the triglycerides are absorbed, and that is the only thing that goes up significantly. So we can, if we go by our cholesterol targets, then we don't actually need a fasting lipid profile. But in the first instance, when you screen people, say sometimes some people can have high triglyceride levels. And if that is the case, then you will have to repeat a fasting lipid profile again. So in that case, for the first instance, it's maybe worthwhile getting a fasting lipid profile. Afterwards, when you want to check whether you have reached your targets, then you can go for non-fasting lipid profile. Again, there is a problem with it because LDL is usually calculated according to a specific formula. They sort of subtract the triglyceride levels, HDL and triglyceride levels from the total cholesterol to calculate the LDL level. So if the triglyceride level is markedly high, you can get falsely low LDL levels. That is a problem. Because of that, you have to be mindful about that. Otherwise, it's okay to get a non-fasting lipid profile. So, so now we have done a fasting lipid profile. In managing patients who have never had atherosclerotic cardiovascular disease, we need to risk stratify them. Risk stratification is done using various tools. So some European guidelines, the NICE guidelines, they offer different risk stratification tools, and it's not validated for our population. But they are very easy to use. They are available online. It's just just putting on the numbers and calculating the risk. But since they are not validated for our population, we use the WHO risk stratification tool. This is validated for us. It's mentioned that this is validated for Sri Lankan population, and what you have to, it sort of takes into account the patient's diabetes mellitus status, whether the patient is a female or a male, whether the patient is a smoker or a non-smoker, their blood pressure levels, and their cholesterol levels. So taking those into account, we can put them into one of these put them into these boxes, and we can see where our patient's risk falls. If it's categorized into more than 30%, 20 to 30%, 10 to 20%, and less than 10%. So in using these cardiovascular risk assessment tools, you saw that they took into account diabetes, hypertension, cholesterol levels, and smoking. But there are several other risk factors that can modify our total cardiovascular risk. So we have to be mindful, and we have to keep in mind that these patients the actual value may be higher than what we calculate using the risk scores. So these factors can affect cardiovascular risk, but not measured in our CV risk score. Premature menopause, obesity, sedentary lifestyle, family history, triglyceride levels, and stress, chronic inflammatory disease like SLE, rheumatoid arthritis, major psychiatric diseases, atrial fibrillation, and patients with HIV, left ventricular hypertrophy. Several of these things can affect the CV risk. So, and again, they say risk assessment is not needed in these patients who are known to have very high risk anyway. So they are patients with documented ASCVD, like I said before, and if their blood cholesterol is very high, total cholesterol more than 309, and diabetic patients with end organ damage, and CKD stage 3 and above, and familial hypercholesterolemia, and high lipoprotein small a, and if they have undergone a coronary artery angiogram, CT angiogram, coronary artery if they have a coronary artery calcium score of more than 100, they say the risk assessment tool is not needed, and they are taken as high risk individuals. So we used to set that even the Sri Lankan guideline says go by LDL levels, start managing the LDL levels, and but now that like I said before, not only the LDL carries a risk. Any lipoprotein molecule with the ApoB can enter the blood vessels and increase our cardiovascular atherosclerotic risk. So because of that, now now there is more focus on non-HDL cholesterol rather than the LDL. So how do you calculate the non-HDL cholesterol? You subtract HDL amount from the total cholesterol. So they say it's more worthwhile managing the non-HDL cholesterol rather than the LDL. However, this is a very recent development. Still, the Sri Lankan guideline says to manage LDL. It has set targets for LDL, and it's all right to follow that too. So, in our guideline, it says if the WHO risk is more than 20%, you target for an LDL of less than 70%, 70 milligrams per deciliter. This is for primary prevention. This is for primary prevention in patients who have never had cardiovascular disease. And if the WHO risk score is 10 to 20%, that is said to be moderate risk, then the LDL target becomes 100. And the low risk patients who are less than 10% in the chart, LDL target is said to be 116 milligrams per deciliter. And in secondary prevention, if they have ever suffered a CVD, LDL target becomes 55. It should be 55. And atherosclerosis, sclerotic cardiovascular disease, if they have had a second event within the past 2 years, say the patient had a MI 1 year back and now presents with a TIA. So they have had 2 atherosclerotic cardiovascular disease events within 2 years, and their target then becomes less than 40. So that is how, that is a rough guide. But the like I said, the new nice guideline is focusing more on non-HDL cholesterol. So this I have taken from the NICE guideline. And what they say is, in these patients, in these people with high risk for atherosclerosis, their risk assessment tool is called Q-risk, and they say if it's more than 10% over the next 10 years, to intervene. And if the patient has type 2 diabetes and their Q-risk score is more than 10% over the next 10 years, intervene. And if it is, again, this is valid for our country as well. If it's type 1 diabetes, if they have one or more of the following things, if they are over 40 years, if they have had diabetes for more than 10 years, if they have established nephropathy, if they have other CVD risk factors, then intervene. If they have CKD with EGFR less than 60 or albuminuria, then intervene. If they are more than 85 in age, there are no evidence for a benefit because that age is a bit advanced. But if they have significant comorbidities, think about starting on statin as a primary prevention strategy. First, you're supposed to, so in primary prevention, you're first supposed to discuss the benefits of lifestyle changes. Say, medical nutrition therapy, how their diet should be, how their exercise should be, and all those things you have to address. And you have to advise them on smoking, cessation of smoking, having a healthy BMI, and stopping alcohol, physical activity, and controlling their blood pressures and HbA1cs. And they say offer people the opportunity to have their risk of CVD assessed again after they have tried to change their lifestyle. This is in primary prevention. And consider other additional risk factors like chronic inflammation, HIV, and things like mental illness. and diabetes, all the other things, and give them a chance to do other modifications. And then, if the lifestyle modification is ineffective or inappropriate, discuss the risks and benefits of statins and offer treatment based on an informed shared decision. We are supposed to have a chat with them and inform them regarding the risks and benefits. And they say in these patients, it's cost effective to go right in with high intensity statin therapy, the lower end of the high intensity statin therapy. So they say it's cost effective rather than starting with moderate intensity or low intensity. So they say start start atorvastatin 20 milligram daily. So if you start on something else like rosuvastatin, start with 10 milligram daily. They say start on 20 milligram daily. And then we have to wait for 2 to 3 months and again do a lipid profile. So they say the target now, their target they have changed, and they say high intensity statin treatment should achieve a reduction of non-HDL cholesterol more than 40% from baseline. More than 40% reduction in HDL cholesterol, not a specific value, but more than 40% reduction. If this is not achieved after 2 to 3 months, discuss treatment adherence, timing of dose, lifestyle, and if the patient is, check whether the patient is at a higher risk than where we have put the patient in, and consider increasing the dose every 2 to 3 months up to maximum dose of atorvastatin 80. And you can, of course, if you think our patients are not able to tolerate atorvastatin 80, especially because the government sector hospitals only have atorvastatin, our hospital only has atorvastatin 10 milligram available. So if you want to give 80 milligrams, the patient will have to swallow 8 tablets of atorvastatin. That is going to be a problem. So in those patients, maybe you can think about stopping at 40 milligrams and adding something else. If patients are on a high intensity statin and have side effects, you are not supposed to take away the statin right away. And you are supposed to offer a lower dose or an alternative statin. And if the maximum tolerated dose of statin does not achieve a non-HDL cholesterol reduction, you have to consider adding ezetimibe 10 milligram daily. And if statin treatment is contraindicated or not tolerated, you can consider ezetimibe monotherapy. Or there are newer drugs which are really not available to us freely. But ezetimibe is available. We can think about ezetimibe monotherapy, or we can think about an alternative statin or something like that. Right. So moving on to secondary prevention. Before going into that, I want to briefly touch upon this. This is about drug treatment for hypercholesterolemia, hyperlipidemia. What I want to show you here is, this is where we intervene with our drugs. So in the hepatocyte, our commonly used drug statin sort of acts on this HMG-CoA reductase enzyme, And HMG-CoA reductase enzyme statin is a HMG-CoA reductase enzyme inhibitor, and it holds the cholesterol synthetic pathway. And now, what does ezetimibe do? We said if statin doesn't work, add on ezetimibe. Ezetimibe prevents cholesterol from getting absorbed. Ezetimibe per se doesn't get absorbed. It prevents cholesterol from getting absorbed. And there are newer drugs, newer approved drugs. There is a drug called bempedoic acid. And this is a drug that arrests cholesterol synthesis a few steps before HMG-CoA comes into action. And there are newer injectable drugs. One is PCSK9 inhibitor. That is an injectable drug. What it does is it prevents the PCSK9 is a molecule. It sort of binds to a LDL cholesterol receptor, and it helps the receptor to be destroyed inside the cell. Because of this action, the LDL cholesterol receptors level goes down. So LDL cannot be taken up by the hepatocyte again. Because of this, what PCSK9 inhibitors do is they prevent this PCSK9 action. So LDL receptor level stays stable. And there is another drug called inclisiran. Again, this helps to prevent production of PCSK9 molecule. So these are the drugs available to manage hypercholesterolemia, which sort of has a cardiovascular risk benefit. All the other drugs that we used to know, some of us, we used to, if the triglyceride is high, we used to start on a fibrate. Or there was other things, bile acid sequestrants. And all those drugs, they say, have no cardiovascular risk benefit. So we are supposed to use these drugs in management. So moving on to secondary prevention. We are supposed to offer statin therapy. So when a patient comes with a MI or a stroke or a TIA, we are supposed to offer statin therapy to all of these patients. And angina, acute coronary syndrome, all these patients. We are not supposed to delay statin treatment. We are like in the previous case. In that case, we gave them lifestyle advice and all the other things, and we tried with other alternative methods. But here, and again here, identify and address all modifiable risk factors like smoking, diet, obesity, alcohol intake, physical activity, and those things. But don't delay start of statins. So here we are supposed to again go with high intensity statins. But prescribe a higher dose. Atorvastatin 80 milligrams daily. In our case, actually, we tend to start a lower dose. Start at a lower dose at 40, even at 40 or 80, you are supposed to start a high dose of high intensity statin. You're supposed to use a lower dose if there is a potential for drug interaction, high risk of experiencing adverse effects, and things like that. And again here, recheck the lipid profile after 2 to 3 months. Aim for a LDL cholesterol of 2 millimoles per liter non-HDL cholesterol of 2.6. This is around, this is LDL cholesterol of about 70 and non-HDL cholesterol of about 100. And LDL and non-HDL cholesterol levels should be reduced as much as possible. They say personalized targets based on clinical judgment and informed decision with the patient. If again the high intensity statin treatment does not achieve the expected results, again check whether the patient is compliant, check whether the patient adheres to diet and lifestyle modifications, and then if the patient was started on 40, increase the statin up to 80. If you have started rosuvastatin, if you have started with rosuvastatin 20, then go to 40. And if that doesn't work, you can think about adding other alternative medicine. Like the first available thing is estimab. Estimab is freely available and we should start estimab. It's very important. I have seen patients come with atherosclerotic cardiovascular disease. They come and they are started on atorvastatin 40. After a stroke or after MI, they are started on 40, and we follow them up. We never recheck their lipid profiles. So if a patient comes with a MI, their lipids change after an MI. So you are supposed to do a lipid profile within first 24 hours before that change occurs. And then take it as a baseline. See whether your target is achieved after 2 to 3 months. This is a must and we tend to miss this a lot. You are supposed to, even after MI, you are supposed to recheck their lipid profile and do the necessary changes, see whether our targets achieved our targets. That's very important and that's something that we tend to miss. So, how do you, this is a brief thing about escalating lipid lowering treatment. If maximum tolerated dose of statin does not does not achieve our targets within 2 to 3 months, consider adding ezetimibe 10 milligram daily. And again, reassess after 3 months. If non-HDL cholesterol remains more than 100, they say consider injectable therapies. Unfortunately, they are not readily available to us. But we can optimize statin treatment. We can think about introducing different kind of statins. We can add ezetimibe. And in near future, these injectables will also be available and they are very easy to use. They have shown to reduce the LDL cholesterol levels like by 50%, that much. And they have persistent effects over long term. So they will be available as well. But for now, try to sort of optimize our statin therapy. And if the targets are not achieved, consider ezetimibe. And there is word about statin intolerance. You must have experienced this. Patients coming and telling various stories about saying that they are not able to tolerate their statins. Here, it has been found that most of these stories, most of the perceived statin intolerance cases are really not significant. Only a minority of them are significant. So what we are supposed to do is, we are not supposed to tell them that this is not significant, just continue taking. If they are complaining of statin intolerance, you are supposed to stop it. Stop the statin treatment and give them some time. Give them 4 weeks. Give them some time. See whether they are symptoms improve. And just improving the symptoms is again not enough. You have to re-challenge them. Start statins again. Start the statin at the same statin at a lower dose or a different statin, and then see whether these symptoms recur. If they recur, then it's valid. It's a valid complaint. Then think about an alternative. If not, you always have to see whether this is a valid complaint. You have to stop, re-challenge, and see whether the symptoms recur. And about so before starting statins, we do the lipid profile. At the same time, you're advised to do a serum ALT and AST, because this is because of the perceived side effect of transaminitis. Statins very rarely cause liver failure, but it causes a transaminitis. So because of this, you're supposed to do a AST and ALT before starting a statin. Do that, and if the AST or ALT is less than 3 times upper limit of normal, then just start the statin. And when you do the follow-up lipid profile in 3 months, in 2 to 3 months, then again repeat the AST-ALT. If there is no significant increase, if the AST-ALT remains below 3 times upper limit of normal, then you can continue the statin. If you are not going to change the dose of statin again, you don't need to recheck the AST and ALT. Right. And but if you increase the dose of statin, if you change something about the statin, if you increase the doses, then again at 2 to 3 months, you have to check the AST and ALT and make a decision. What about the most common 2 side effects are liver transaminitis and the myopathy, myositis, right? So myositis is rhabdomyolysis can happen, and rhabdomyolysis is a fairly serious side effect. So you're not supposed to do a creatine kinase before starting statins, because right, but if the patient before starting statin, if the patient is complaining of muscle symptoms, muscle pains, then only you are supposed to do a baseline creatine kinase level. If this creatine kinase level is normal, then go ahead and start on the statin. If it is elevated, what should you do? If it is elevated more than 5 times upper limit of normal, don't start the statin. Think about something else. But if it is if it is not normal, if it's high but still less than 5 times upper limit of normal, you can start on the statin. And again, if the patient is on statins and if they complain of muscle symptoms, you're supposed to do a creatine kinase. If the level is more than 5 times upper limit of normal, stop the statin. Give some time for the statin to get out of the system, and then restart at a lower dose or start on a different statin and see how it goes. See whether you can achieve the cholesterol targets and see whether the muscle symptoms reappear. And if the CK level is less than 5 times upper limit of normal, it is said that you can continue. A word on triglycerides. So, when we do the lipid profile, we get HDL, our total cholesterol, our LDL, HDL, and our triglycerides, and our VLDLs. So, if this triglyceride level is high, what are we going to do? Are we going to, so a few years back, the thought was, if it's triglycerides, start on fibrates. And this is now advised against because um, fibrates have not shown to be of any be not shown to have any cardiovascular cardiovascular advantage in the studies. Because of that, even if the triglyceride levels are high, you are still supposed to risk stratify your patient, start on the proper dose of statins, and at your routine assessments, see whether LDL target is achieved. So if the LDL target is achieved and still the triglyceride level is high, then you're not supposed to again fibrates is not the option. Even though it's not really available in Sri Lanka, there is this fish oil, icosapent-ethyl, and a fairly high dose of this fish oil supplements. We are supposed to use that because of their anti-inflammatory mechanisms. They have been shown to have some cardiovascular benefit. So the next treatment that we are supposed to consider is icosapent-ethyl, that fish oil supplement at high dose, at 4 grams per day. And it's really not available in Sri Lanka, but that is the next recommendation. But only after that, if still the triglyceride level is very high, and because of the risk of pancreatitis, then you can think about adding a fibrate, because combination of fibrates and statins again can cause, there is high risk of muscle symptoms. But if the triglycerides are very high, then you can add on a fibrate, but not as a first line. Even if the triglycerides are high, you are still supposed to start on a statin, not a fibrate. So that is something I need to tell you all. That sort of concludes my presentation. I would be happy to answer any questions that you might be having.
Madam, there are a few questions in the chat box. The first question is, what is the use of HSCRP in primary and secondary prevention in Sri Lanka?
Sorry?
What is the use of high sensitivity CRP, HSCRP in primary and secondary prevention in Sri Lanka?
So that is again, because of the availability and everything, that has not come into recommendations. High sensitivity CRP is sort of a marker that you can use to risk stratify, but it's not used in to risk stratify people in Sri Lanka or in other guidelines.
Another question, do we need to withhold the statin dose previous day before doing the lipid profile?
No. So once you start the statins, when you monitor the treatment, it's always with the statin, even with the it's the same for any sort of non-communicable disease. You're supposed to monitor treatment with the effect of the drug. You are not supposed to withhold the drug.
Okay, madam. Why we have to take the statin only at night?
That is the recommendation. Actually, I don't have a clear-cut answer to that. That is how the drug is. That is how we administer the drug. I'm sorry, I don't know about the good answer to that question.
Another question, can we stop statins in secondary prevention and the risk of diabetogenesis of long-term statins?
No, actually. I don't know whether I think I skipped that point. if you bring down statins by 1 millimoles per liter, if you bring down LDL cholesterol by 1 millimole per liter, your cardiovascular risk comes down by about 22%. So that much of benefit is there in bringing down your cholesterol, even though statins at long term at very high doses in elderly people can cause increases in blood sugar. The benefits that it confers it is said to be much higher than that risk, and it doesn't happen in all the patients. So you are not supposed to withhold statins if your patient's blood sugars start rising. It can be due to statin, it can be due to many other things. So you are not supposed to stop the statin.
The initial starting dose of atorvastatin 10 milligram is not enough.
So like I said, there is this classification of intensities in statin therapy. So atorvastatin at atorvastatin treatment, now the latest guidelines say start at 20 milligrams, because they have found that the benefit is when they sort of calculate the cost and benefit analysis, when they have done that, and they have found out that it's much more cost effective starting statin at 20 milligrams. So now they recommend even for primary prevention, start at 20 milligrams. That is the recommendation. But of course, considering our patient, it's always individualized treatment, considering the patient's preference, if the patient prefers a low dose, if you think the patient may not be able to tolerate, if the patient has other problems, if we are worried about drug interactions, then of course you can start on lower dose of statin. But now the latest guideline recommendation is start at 20 milligrams.
Madam, is there a risk stratification tool for patients who are less than 35 years? And if so, what are the treatment targets for primary and secondary prevention?
The secondary prevention is always all the same, whatever your age is. Secondary prevention is, if you have suffered atherosclerotic cardiovascular disease, that is secondary prevention, and the treatment goals are the same, right? So you are supposed to reduce their non-HDL cholesterol by 40% at 2 to 3 months interval. For primary prevention, again, it's the WHO risk assessment tool.
Madam, is there a significant benefit in using atorvastatin versus rosuvastatin?
There is no difference. Rosuvastatin is said to be more potent, but the rosuvastatin, atorvastatin 40 is equivalent to like rosuvastatin 20. That is, the rosuvastatin is more potent, it's said, because of there is no advantage as such. Patients might be responding to different drugs differently, but it is not said that generally rosuvastatin is not a better drug than atorvastatin. There are other problems. Yeah.
In a patient who had a MI, do we need to continue atorvastatin lifelong even if the lipid profile is normal? What is the correct practice or any other alternative medicine we can use?
Yeah. So that's a good question, because after an MI, if the lipid profile, there's nothing called a normal lipid profile now. That is what we have to understand. The reference ranges given by the lab, those are you just disregard those because it's always individualized. When you read a lipid profile, it should be individualized to a patient. So after an MI, you do a lipid profile at before 24 hours, right? And you see, say your lipid profile, your LDL cholesterol becomes is something like say 70, but still you are supposed to start on your high intensity statin therapy, right? And then try to achieve the target. Try to reduce that 70 by 40% at 2 to 3 months. I know that is a very low value, but it has been found, and there is no data to say that very low cholesterol levels is harmful. It's the at the when the event happens, if your cholesterol was 70 and then you're supposed to cut it down by 40%, and if when you achieve that target, it's something like 40 something, that's okay. You're supposed to continue your LDL cholesterol or non-HDL cholesterol at that level. You're not supposed to stop the statin. You're not supposed to go for a alternative if on the basis of a very low LDL cholesterol or very low non-HDL cholesterol. The only place where you should consider alternative is when your targets are not met. Am I clear?
Yes, madam. And there are other questions. What is the management of a patient who is on statin with progressive CPK levels? And also, can we start statins in patients who already have high AST ALTs?
Like I said, so ASTLT, if it's more than 3 times upper limit of normal, you're not supposed to start on a statin. You can monitor their liver functions. You can advise lifestyle modifications, do other risk factor correction, and try to bring down the AST/ALT, and then think about starting on a statin. But you're not supposed to start a statin if the AST/ALT is more than 3 times the upper limit of normal. About CPK, like I said, if the CPK level is less than 5 times upper limit of normal, then you can continue your statin safely. But you have to keep an eye on the CPK. But say your patient is symptomatic, complaining of things, looks like the patient is not tolerating it. And even though the CPK is less than 5 times upper limit of normal, maybe stop the statin. See whether when the statins go out of the body, give sufficient time, about 1 month. See whether when the statins are cleared from the body, the symptoms improve and CK levels come down. And then re-challenge. Start a lower dose of the same statin or a different statin, and or lower dose of a different statin. You can go either way. And then see whether the CPK levels increase again and whether the symptoms reappear. That is how you differentiate between that.
Okay, madam, another question. What is the place of omega-3 and fish oils in the management of lipids?
Again, like I said, this is given in when, so there is a place in hypertriglyceridemia after you have given the optimum statin treatment. After you have given the optimal statin treatment, in secondary prevention, if still the triglyceride level is high, then you can think about fish oil. Adding fish oil. That fish oil also is not what we have available in Sri Lanka. In Sri Lanka, what we have is DHA and EPA combination 1 gram usually. So that is not adequate. What they say is they have purified this omega-3 fatty acid icosapentaethyl, and they say to give it at a very high dose, 2 grams BD, 4 grams daily. So that is is the place. That is the only place. You are not supposed to like routinely, if you advise a patient to take omega-3 fatty acids routinely when looking at their lipid profile, at the doses available, at the current doses available, the routine preparations won't confer any benefit, they say. They haven't found any benefit with that practice. Only at that specific indication, when the optimum statin therapy has failed to bring down the triglyceride level. Am I clear?
Okay, madam. We are receiving a lot of questions. We will answer them via the WhatsApp group, and we are going to wind up the session today. On behalf of the participants and the Society for Health Research and Innovation, I sincerely thank Dr. Situmini Pahalagamage, a consultant physician of the National Institute of Infectious Diseases, Colombo, for your very informative and timely lecture and for spending your time to educate us. Also, there will be a link in the chat box to give your feedback and answer the post-assessment questions to receive your e-certificate for participation. And I thank you all for your enthusiastic participation. Thank you very much. Thank you, madam.